Thank you so much. Radiation therapy, as you know, it's an integral part in the treatment of breast cancer. Can we tailor our radiation therapy to the individual characteristic of the patients, like to the breast subtypes? We know in the last few years there has been so many advances in the way to deliver the radiation therapy. We are now delivering the radiation much more precise to the target volume. We have IMRT, VMAT, stereotactic. All this will deliver the radiation very sharply to the tumor only and protect the normal tissue. The radiation, mainly we give it for local control to improve the local regional control, either after the breast conservative surgery or after mastectomy or after neoadjuvant chemo and surgery based on stage. As a matter of fact, when we see the patient, usually we see first whether he is fit to receive radiation or not, his age, any comorbidity, and we base our decision on the classical pathological factors that we have: tumor size, lymph nodes, grade, and so on, surgical margin. These are mainly the feature that based on this we decide whether to give radiation therapy or not. But when you look to the local recurrence after the surgery, it's not the same. You have a very favorable group of patients where the local recurrence is quite small, where partial breast irradiation could be more than enough for this patient. And you have on the other extreme a high-risk patient for local recurrence that even whole breast irradiation is not enough. You need to give a boost to improve the local control. So it's not all the same group. So this is why you have to be sure when you give the radiation therapy, the patient benefit is more than the side effect or the expenses. Recently, the breast cancer has been divided into many subtypes that you all know, and these subtypes have been very influential in the medical oncology. Many patients used to have chemotherapy, now they don't have chemotherapy, and so on. But how this is applied to the radiation therapy are these subtypes affecting our decision to give the radiation therapy? So just simplicity that we have the luminal A, the HER2 cancers, and the bad ones, the triple negative. Of course, it's a little bit more complicated, like even the triple negative, it has many subtypes and so on. So is there any relation between these breast subtypes and the local control? Unfortunately, we have only retrospective clinical data to address these questions. Many authors reported the local recurrence according to the different breast subtypes, okay, after breast conservative surgery. And as you would expect, the luminal type, they have a very low risk of recurrence, and the bad ones are the triple negative. For the HER2, there is a big difference when you read the data before trastuzumab and after. It's a huge difference. Like after the introduction of trastuzumab, almost it became like luminal disease. A similar pattern was post-mastectomy also, that the luminal disease have very low risk, and the triple negative is the bad ones. And of course, these are the recurrences before the use of the trastuzumab. So there is also a big meta-analysis of 15 retrospective studies over 12,000 patients post-conservative surgery or mastectomy, also looking at the same issue and confirm the same findings, that the local recurrence in the luminal type is much lower than the triple negative. Okay, so there is a relation between the breast subtypes and the local recurrence. So let's start by the good ones, the luminal type. If the local recurrence is very small in this subtypes, can we omit radiotherapy? Do they need the radiotherapy to start with? Can we omit the radiation and toxicity and the expenses in certain group of patients with ER positive disease? Actually, this issue being addressed in at least 3 well-done prospective randomized trial, where they try to identify really a low-risk patients. They took the elderly, small tumors, receptor positive, And they found even in this subgroup of patients, radiation therapy improved the local recurrence from 9% drop it down to 2%. So there was no consensus. Can we use a better selection based on genomic profile to identify the really low risk patient? And there is ongoing studies now, stage 3 prospective trials. They took this very favorable group of patients, hormone positive, HER2 negative, no lymphocyte invasion, low grades, negative margin. And on top of that, they had another selection criteria, either KI67 less than 13%, the oncotype DX less than 18 in this trial, and this trial used the PAM 50 less than 40 in this trial. So they did not publish yet the results, but maybe by using this genomic profile, we will be able to better select the really low-risk patients and where we can omit the radiation therapy that have a very low risk of recurrence even without giving them radiation. Now in the HER2 positive, you really need to separate the data between pre and post the use of trastuzumab. Because if you look to the time trend in this study, young patient, over 1,000 young patient, early stage, from 2003, 2008, and here this is chemotherapy used along all the years, hormonal therapy used along all the years, and then here where the immunotherapy trastuzumab been introduced. And you could see this is a line of the local recurrence. It dropped since we started HER2 for the HER2 positive, of course, patient by about 50%. So now in this group of patients, if you use both radiation and the trastuzumab across the available studies, the figures is about from 8% drop down to 4%. And we know for the HER2 positive, if they are also ER positive, they do much better than if they are ER negative in terms of the local control, 2% versus 6%. So now we come to the really bad ones, the triple negative one in terms of the local control. Even this group of patients, the triple negative, when you look to the data of partial breast irradiation, they did the sub-analysis for these patients who had triple negative, and they found the local recurrence was high. So they are not a suitable group for partial breast irradiation. So for the triple negative breast cancer, you should not give partial breast irradiation. You have to do whole breast irradiation. If there is a subgroup where you should give a routine boost, this will be the group because of high rate of local recurrence. And many patients now, they are getting new adjuvant chemotherapy, and then we sometimes have an issue about the lymph nodes in the axilla, whether we treat or we don't treat. This is the group where we tend to treat because we know the local regional recurrence high in this group of patients. In terms of the hypofractionation, giving less radiation fraction with larger doses, if you look to the guidelines, there is no mention about the molecular subtypes of the breast cancer. Although people had looked to the famous Canadian hypofractionation trial, and the disease-free survival at 10 years, 95% for luminal A and basal-like, 92 for luminal B, and 83 for HER2. It's interesting why the basal-like is radiosensitive, maybe due to deficiency in DNA repair in this group of patients. And there is no data yet about the concurrent use of the boost according to the breast subtypes. Okay, so now we have what we call the radiosensitivity. Is there a different sensitivity for radiation to different subgroup? I mean, it's still unknown that whether different subtype had different sensitivity to radiation therapy. Maybe ER is radio resistant and we need to give more radiation, escalate the dose. Using trastuzumab may have reversed the radio resistance that used to be of the HER2 disease. Now this is a new term, radiation sensitivity index, RSI. It's a radiotherapy specific multi-gene expression model to estimate at the cellular level the cellular radiation sensitivity. When they apply this index on the EORTC boost trial, it's interesting to know that those who benefit from the boost are those who were classified as RSI sensitive group. So this RSI in the new index can be used as a biological base to make the decision to prescribe your radiation dose. This is a new term, radiogenomics. Basically, it's an interplay between the genomic elements and the radiation response at the cellular level for the tumor and for the normal tissue. It will allow us to give the radiation more personalized radiation, customized to the patient, to predict the tumor radiosensitivity and to predict also the radiation toxicity. The dream of our radiation oncologists is that once we have patients referred for radiotherapy, we do some gene profile studies, and we will be able to classify them into more radio-resistant tumors, where you need to escalate your dose or to add any sensitizer, chemo, or anything, immunotherapy. Or the other one, which are very sensitive, unfortunately, sensitive will be the normal tissue and the tumor, and then we need either to de-escalate your dose or give a small dose per fraction or more conformal radiation therapy. So in conclusion, tailoring radiation therapy according to the breast cancer subtypes, are we far from this? The answer is the data is really emerging in the last few years. We still need validations for most of these data and the prospective studies. Thank you so much.